A very good evening and welcome everyone. I, 𝗟𝗘𝗧'𝗦 𝗦𝗛𝗕𝗏𝗧, on behalf of Voice of Healthcare, welcomes all the speakers and the viewers who have joined in for today's discussion. On the occasion of Breast Cancer Awareness Month, Voice of Healthcare, in association with AstraZeneca, has taken an initiative to bring together the experts and speakers for the episode 2 of Take It Off Her Chest panel discussion, which aims to know the importance of early detection of breast cancer. With this discussion, we shall also dive into understanding the relevance of genetic testing in breast cancer treatment. I would like to commence this session by introducing our eminent speakers. So, for today's discussion, we have Dr. Prashant Mehta. Sir is a senior consultant and assistant professor of the Department of Medical Oncology, Hematoncology, Bone Marrow Transplant at Amrita Institute of Medical Sciences, Faridabad. Welcome, Dr. Mehta.
Thank you.
We have Dr. Kaushal Kalra. Sir is a medical oncologist at Vardhman Mahavir Medical College and Safdarjung Hospital, New Delhi. We have Dr. Astha Dayal ma'am. She is a senior consultant of the Department of Obstetrician and Gynecologist at 𝗃cie 𝗶𝗰𝗲𝗏 Hospital, Gurgaon. Welcome, Dr. Dayal.
Thank you.
We have Dr. Deepak Kumar Shukla. Sir is a consultant medical oncology at Manipal Hospitals, Jaipur. Welcome, Dr. Shukla.
Thank you.
We have Dr. Pradeep Kumar Mondal. Sir is a consultant medical oncologist and hemato-oncologist at Medica Super Speciality Hospital, Kolkata. Welcome, Dr. Mondal. We have Dr. Meenu Walia. Ma'am is a senior director medical oncology at Max Super Speciality Hospital. Welcome, Dr. Walia. Along with sharing her views, Dr. Meenu Walia will also be moderating today's session. So without further delay, I would like Dr. Meenu Walia to lead this session. Over to you, ma'am.
A very warm welcome to all of you, and many thanks to Voice of Healthcare for this opportunity. I hope we have a very fruitful discussion on this platform today, which is worthwhile for all the audience who are watching us. So, as we talk about breast cancer, we all understand that breast cancer is a growing epidemic, not only in our country but all over the world. While 2020, the world knows it the only as a disease, as the year with the coronavirus pandemic. But what many people don't know is that lot many things had also changed in the oncology front in the same year. Breast cancer became number one cancer all over the world. A cancer which seems to happen, which majorly happens in 50% of the population, and basically in the females, majorly in the females. But still, it is the number one cancer all over the world. It does signify that there's a lot to be worried about in the coming times. So while we all know that cancer is due to genetic changes, due to certain changes that happen in your genes, and these changes in your genes can happen because of lot many factors, maybe lifestyle related, but yes, some of these genetic changes can be inherited also. So can be because of inherited genetic mutations, and that is what we want to discuss in today's panel. And let us see whether all breast cancers are because of inherited genetic mutations. If no, then which one, what percentage, how to identify, which are the patients who should be getting the genetic testing done, and what is the relevance of genetic testing. If at all there are genetic mutations, what does it mean? What does it mean for the patient? What does it mean for the rest of the family? And what all that can be done to pick up things early, to detect breast cancer early. And without much delay, I'll now invite all my panelists so that we have a very fruitful discussion today. And I hope all of us are there. And just to sensitize the public about what breast cancer is all about and what is the inherited proportion of inherited breast cancer. So, if Dr. Kaushal is there, uh, has Dr. Kaushal already joined? So I do not see Dr. Kaushik. So let me have the first question addressed to Dr. Prashant. Uh, we have certain causative agents for so many diseases. For example, we know that the COVID pandemic was because of coronavirus. Some of our cancers also now, for example, the cervical cancer. We now know there is a causative agent, there is a human papilloma virus. Are things so simple for breast cancer? Do we have any causative agent, or we need to depend, or we need to identify any risk factors for which patients are those who are at risk for developing breast cancer? So, Dr. Prashant, will you please take this question?
Yeah, surely. Thank you for your question, ma'am. So this is an important question, and people, women especially, must know that what are the risk factors for getting this disease, breast cancer, which is the most common cancer, as you said. So yes, there is some risk factor. There are some risk factors you cannot modify, so they're non-modifiable, and some are modifiable. You can change them, you can alter them, and you can reduce your risk. So let me talk some of the non-modifiable factors. The non-modifiable ones is, first one is age. So everyone gets older, and breast cancer is more likely to happen in people who are more than, let's say, 40 or 50 years of age. So as you get older, your risk for breast cancer can increase, and it does increase. And we see in India, although the average age is a little lower than the West, but yes, it is still happening more as you age. And other risk factors are, like, which are non-modifiable, is the genetic mutations, as you said, and we are discussing the genetic mutations actually today in more detail. So mutations like BRCA1 and BRCA2, and some other mutations also, like p53 alterations and PALB2 and so many others, they can also increase the risk of getting breast cancer. And another important factor is the duration of hormone exposure in a woman's life. So that is, if you have an early menarche, beginning of menses at an age before 12 years, or the end of menses, that is menopause, beyond 55 years of age, 55 years of age. So that's a longer exposure to your hormones. So that also increases the risk of getting breast cancer. So this is also a non-modifiable factor. You can't do much about that. So another factor is having a personal history of breast cancer, or having certain non-cancerous lesions like atypical hypoplasia or lobular carcinoma in situ. These can increase the risk of getting breast cancers. Family history of cancer is also an important factor, especially first degree relatives. And there's a cluster if there is a clustering of cancer in the family, especially male breast cancer even in one first degree relative, or ovarian cancer in a first degree relative, and clustering of breast cancer in your paternal or maternal family, first degree relatives, or multiple cancers, or having cancers in both breasts. These could be actually due to genetic predisposition. So these actually increase the risk of cancer, and these are genetic factors, so again, non-modifiable. So any previous treatment with any radiation, like when you are below 30 years of age, let's say radiation for Hodgkin lymphoma, if you've got chest wall radiation, it also increases the risk of getting breast cancer. So now, coming to the risk factors which can actually change, which is the modifiable factors. So if you are not physically active, that's something you can modify, and you can keep your weight under check. You can prevent obesity and sedentary lifestyle. So being physically active, yes, it does reduce your risk. Maintaining a healthy weight does reduce your risk. So if you're taking hormones, let's say you're taking a combined estrogen and progesterone pill, like a hormone replacement therapy or as an oral contraceptive, taking these more than, for a longer period, let's say for a period of more than 5 years or so, that also seems to increase the risk, and it can be modified. So it is something which is under our control. So other, things which are could be modified is a reproductive history and breastfeeding. So breastfeeding decreases the risk. If you are not breastfed, it could increase. And having a late first pregnancy also, increases the risk. Having alcohol, as even in women, consuming alcohol, it increases the risk, and it's also a modifiable factor. So these are some of the modifiable factors which we can actually, act upon and reduce the risk of getting breast cancer.
So, thank you, Dr. Prashant. I think you made very relevant points here, talking about modifiable and non modifiable risk factors. I believe the audience will understand while you may not be able to do something about the non modifiable risk factors. If you're a female, or if your age is increasing, or you had a early menarche or a late menopause, or you have had some treatment in the past like radiation to the chest wall, or there is a family history of breast cancer, these are the things you cannot change, you cannot do anything about it. But still, it helps in knowing because it will help you be prepared, or it will help you understand your risk for breast cancer, and you will understand how aggressive you need to be, how more cautious you need to be. But on the other hand, there is a whole list and rather very important and other factors which we say are modifiable risk factors, and a lot can be done about it. For example, the age at which you get married, the age at which you have your first child, whether you breastfeed your child or not, and how long, whether you use hormonal replacement therapy for menopausal symptoms, and whether you are physically active, how much of physical activity you do, what kind of food you take, and what are your lifestyle factors. These are something which are modifiable, which you can really change, and if you understand this, you can really reduce your risk of breast cancer. So thank you, Dr. Prashant, that was wonderful. And we
Thank
now,
you.
I believe Dr. Kaushal is there with us now. So coming to, while we understand about the risk factors for breast cancer, like the modifiable and non-modifiable, another important thing that came up about is the family history of breast cancer, and that is also something which we said a non-modifiable risk factor, and we need to be aware of that. So Dr. Kaushal, I will want to know from you that what is the percentage of breast cancer cases which you feel are because of inherited genetic mutations in your clinical practice, and what percentage of patients who have a strong family history of breast cancer, all the new breast cancer patients that you see in your clinical practice?
Yeah, in my clinical practice, I think approximately 10 to 15% patients are from this hereditary cancer group, and strong family history is present in around 5 to 10% of patients. This is strong family history. With the family history of the breast cancer or ovarian cancer or pancreatic cancer, 5 to 10% patients have family history.
So I think that is a very valuable insight, take home for all the audience there. While yes, breast cancer because can be because of inherited genetic mutations, but it is not more than 10 to 15% of these cancers which are because of inherited genetic mutations. And breast, in the vast majority, sometimes you do not even have a family. Many times rather, you do not even have a family history of breast cancer. So, Dr. Deepak, I mean, in today's date, we have now started talking a lot about genetic testing, especially we take a detailed history, we make the pedigree tree and what all other family members had cancer. So, what is your take on that? If you are advising a genetic test, so do you advise genetic testing for your patients? And that is what we will want to know. And if you advise a genetic test, then how do you select this patient? Which are those patients? Do you advise for all of them, or you do some selection? And which are those patients where you would like to do the genetic testing?
Okay. Thank you, ma'am. So I definitely offer genetic testing in my clinical practice. So not all breast cancer patients are candidates for genetic testing at present. So as already mentioned that the overall burden as such is close to 5 to 10% or less than 15%. So the patients who are candidate for genetic testing according to the guidelines are breast cancer who are triple negative. So we have a type of breast cancer which does not express ER, PR or HER2/neu. So this type of breast cancer is called as triple negative breast cancer. And a female with this type of breast cancer, irrespective of age, is one of the candidates for offering genetic testing. Other than that, as already discussed, the if a patient suppose she is less than 50 years of age and she has history, a family history of multiple first or second degree relatives with cancers like prostate, pancreatic, ovarian or breast, then again she will fall into one of the indications of offering genetic testing. In addition to this, male patients who are having breast cancers, they are also candidates for genetic testing. And based on the family history of the patient, one may be assessed whether they have a history of means multiple cancers in their family, and they can be again assessed whether genetic testing is needed or not. And some of the patients which we see sometimes have breast cancer on one side of the breast, and subsequently they develop on the other side, that is contralateral breast cancer. Again, these patients are also candidates for genetic testing. There are certain races or where in the West, like Jews and Ashkenazi Jews, where they offer, but that is not much relevant in the Indian context. And these are possibly the patients where I'll discuss genetic testing. And now, particularly in 2022, we know that we have a drug that is available with us, and possibly one more treatment options to offer to our patients. So patients who are having a breast cancer which is HER2 negative, and the patients based on the clinical risk factor,
So,
she can
Dr.
be
Deepak,
offered olaparib also.
Dr. Deepak, we will come to that later. But I
Okay.
think you brought out very pertinent and very important points about genetic testing. Because for a layman, it is only a strong family history of breast cancer. They feel that people who have a very strong family history of breast cancer, only those are the candidates for genetic testing. And other times, whenever an oncologist is advising genetic testing, the first question is, we there is no family history, nobody in our family had breast cancer. So very important take home points are that it is not always a very strong family history of breast cancer that genetic tests will be advised by your oncologist. Many times it is the type of the breast cancer, the molecular profiling of your breast cancer, as Dr. Deepak said, a triple negative type, which is a variant of breast cancer which has a higher proportion of these cancers compared to the others have a genetic mutation. So if it is a triple negative breast cancer, apart from that, it is not always a family history of breast cancer. Sometimes a family history of there are other cancers apart from breast cancer which may be relevant. For example, a family history of pancreatic cancer, a family history of young prostatic cancer or a high grade prostatic cancer in the family, and breast, ovarian, endometrial. So it is not just the family history of breast cancer which is important. So a family history of so many other related cancers which also becomes important, and these are certain parameters on which your oncologist generally advise you to go in for the genetic testing. So we have a very senior gynecologist, Dr. Astha, also with us today. Welcome, Dr. Astha. So, are you, Dr. Astha, if I can ask you in your clinical practice, because all these cases which are treated by we oncologists, before they come to us, they are generally seen by you. and after they're treated by us, majority of them will go back to you and will be on your follow-up. So you must be having lot many people or lot many patients whose families have breast cancers. So how frequently you see that these people are aware about genetic testing, or these people when they come to you they have already got their genetic testing done?
So actually, ma'am, I practice in a corporate setup, and I do have patients. The kind of patients I get are a little aware, and if they've had a first degree relative who's had a cancer in a young age, they've actually taken treatment where the genetic testing has been offered to the patient itself, and then patient herself, and then that has been communicated to the rest of the family. But there are a lot of patients who do have a family history and the index case was not even offered a genetic testing, which is unfortunate. And sometimes people who are coming from tier 2 cities and tier 3 cities and staying in Gurugram, they generally are not very aware of these tests availability and whether they have a significant family history. In fact, a lot of them are also in denial. So a lot of patients just come to me for a routine health check, and unless I probe into the family history, they don't come up with the history of a cancer because of the stigma attached. And sometimes they don't even know which type of cancer is clustering in the family. They just know there was something in the stomach or some metastasis. They don't even inquire about the details of that cancer in their family. And I think majority of India is like that. So it is important that we as gynecologists have to, at every visit, we need to be probing into the family history so that we understand whether the woman is in high risk or not. And because I think our responsibility is to triage it and then send it over to the oncologist or the genetic tester.
So again, thank you, Dr. Asta. I think you made a very relevant point here, because many times, because of the stigma attached to history of cancer, and especially in our society, many people are not so forthcoming with their even oncology history about history of cancers in the family, unless there are direct questions that are asked to the patient, and unless we ask direct questions and make them aware of the implications of it. And so much so, I would rather say that we oncologists also, even if we sometimes we do see patients where there have been history of cancer or a prior cancer, now it's a second malignancy, unless direct questions are asked, because of the stigma, because of so many factors, people are sometimes not so forthcoming. And yes, so that is the reason we need to sit with them, talk with them, and then try to ask and make them understand the relevance of all these histories. So coming to, if we all realize that yes, this is history is important, then as I think Dr. Deepak wanted to touch that point. So Dr. Kaushal, I will come back to you again. In case, I mean, if you know that your patient is BRCA mutant or is BRCA mutation positive, so one of the genes commonly associated with breast cancer, she is BRCA mutation positive. Does it make a difference to you? Then if yes, then what difference will it make? So Dr. Kaushal, you are on mute. Can you please unmute yourself? Yeah.
Actually, treatment may differ. Treatment may be modified. If patient is mutation positive, we know that she is mutation positive. Like one, the patient is non-metastatic. There is data. Patient is having triple negative breast cancer and no PET CR. Then we can add adjuvant after surgery. We can start after treatment, complete treatment. We can start treatment drug olaparib in the BRCA mutated patient for a year. If patient is coming with the upfront metastasis stage, then we can give olaparib single agent in place of chemotherapy for the till progression, and it will increase this progression free survival. This thing, one thing. And another thing, if patient is having mutation positive, we can go for the risk reducing surgeries upfront. Like if patient is going for the mastectomy in breast cancer, we can go for mastectomy for another breast because patient is mutation positive. If patient has mutation positive, then there is more chances for the cancer, development of cancer in the future. So risk reducing surgeries like another breast mastectomy, salping of, we can remove ovary. We can ask the patient to opt the option, so that it may decrease the chances of further incidence of any malignancy in the same patient. Another thing
So,
we can, yeah,
yeah, you want to say something? Please make your
no,
point.
no, no, yeah.
So I think you had very crisply made your points clear that knowing a particular mutation makes a difference. It makes a difference not only for the patient per se, it also makes a difference for the rest of the family. While for the patient per se, I for a layman, probably they feel if we get the genetic testing done, that only makes a difference for the rest of the family members. But in today's state, the era of precision medicine, now there are lot many different changes. We do understand that cancer is not one disease. What is happening at the molecular level, what is happening at the genetic level, that has a lot of relevance, and you do have different treatment options for different kind of cancers. So if we know the BRCA mutation or the mutation, the genetic mutation status of our patients, then there is a lot of difference in the way we manage these cancers. For example, it is not only in the medical treatment, like as you said about the PARP inhibitors, olaparib, etc., which can be given in the medical management. It also makes a difference in the surgical management. A patient who is probably, you must be preparing for a breast conservative surgery, and if you know the BRCA mutation status prior to surgery, you may actually think of going ahead and doing a bilateral mastectomy, reducing the risk for the other breast also, and probably you can also plan the other prophylactic surgeries. So, this brings to us a very important pertinent point is that if at all we ask for genetic mutations, then what is the right time? Which time? What is the right time during the disease course that we should ask for these testing? So, Dr. Prashant, can I have two words from you on this? And Dr. Prashant, you are on a mute, please. Dr. Prashant, can you unmute yourself?
Let me unmute. Okay, yeah. So now I think you can hear me. So it's the most important part is the genetic counseling, and it is generally done by either a physician or a clinician or a genetic counselor. So before you embark upon testing, and you need to explain all the associated situations which could arise because of the genetic mutation being there, and it is a process which the patient and family and the doctor have to undergo, and it is a complex interaction actually. But yes, you are saying that you're asking me when the test should be done. It should be done as reasonably early as possible, but yes, after a proper discussion between the family and the treating team. So yes, I would do it at as early as possible during my interaction with the patient. If the genetic testing is indicated based on the family history or the type of tumor patient has, so I would rather do it early rather than late.
And how frequently in your clinical practice you feel that you are able to convince the patient to go in
I
for
I
genetic
I,
testing?
lo- I lost your voice in between.
So, what I was asking is how frequently in your
Again,
clinical
again, I'm losing
practice.
you.
So, am I more audible now?
You're intermittently audible, but I think you can.
So, I just wanted to know how frequently in your clinical practice you are able to convince the patient for.
Okay, fine. So how frequently I am able to convince the patient to do a test?
Yeah.
Okay, so I think uh, most patients are convinced with the idea and they understand it if spoken well regarding the whole problem. And I think most patients do connect with the problem at least. They might not do it right away, but I think we need to give them time. And I would say if we take into account don't take into account those who test late, like maybe after treatment or later in the course of the follow up. I think I am able to do tests for most patients wherever it is indicated. For ovarian cancer, the compliance is very high, and in fact, it is a part of the treatment protocol now. But for breast, I think it is getting there, and we are able to do, and especially that there are some support programs also available now, and the cost of the testing has come down. So I think some of the roadblocks have gone away, and I think we have also gotten better at discussing the situation, because there is awareness amongst the clinicians as well as the patients now, especially some of the
So, So I think we lost Dr. Prashant. So I will now invite Dr. Pradeep to take it on further. So, Dr. Pradeep, do you also feel like, as a other oncologist on a panel, that genetic test is required in the treatment of breast cancer patients, at least in some of the breast cancer patients? And what difference does it make in the treatment?
So I'm sorry, I just lost my connectivity, I think, for a bit.
Yeah. So, Dr. Pradeep, are you there?
Yeah, madam. Can you please repeat the question? I lost it.
So,
Hello.
I basically wanted again from you, like understanding the genetic testing. Do you agree that a good chunk of your patients, breast cancer patients, require genetic testing, and it does make a difference in their treatment?
Yeah, of course, madam. That genetic testing is not only for that patient, but of course that we have to understand that what is the risk of that sibling or other family members. So that is very important. So basically, that genetic testing is very important because for the patient's perspective also, that we can that prophylactic surgery because that we can remove the opposite breast also, ovarian, all these things, that prophylactic surgery, oophorectomy, all these things for the patient. And of course that to decide about the therapy, whether we can have some targeted therapy which is available, we can give or not. And from that patient relatives perspective also, whether there is a that disease is running in the family, that genetic that basically runs in the family, that is also very important. So basically genetic testing is very important, not from the patient perspective, also from that family perspective also.
Yeah, I think again a very pertinent point that for the rest of the family members also, genetic testing becomes very important, because there are difference in the way you generally screen these people. So the screening guidelines for patients, for people who belong to high risk families, are slightly more aggressive than screening guidelines for a general population. And you can actually offer them a lot of risk reducing surgeries and other options too. And so coming to the breast cancer, not all of them are genetic, that we do know, but due to inherited genetic mutations. But in advanced breast cancers, the things, even in advanced breast cancers, the scenario seems to be changing. So apart from just the classical treatment that we used to have, so Dr. Deepak, I will want to have your comments on what you say even about metastatic breast cancer patients. So majority of the, in today's date, if we see even metastatic breast cancer patients, what are the different options that are available, and is the scenario really that grim as it used to be earlier, or the things are changing now?
Yeah, so ma'am, the metastatic breast cancer, again, largely it remains incurable, but the outcomes have improved dramatically. And I can say that confidently, we all agree, mostly because of the treatment options for approximately 70 to 80% of these patients, the outcomes have improved. We are touching the survival close to 4 to 5 years median survival in metastatic breast cancer, particularly in the hormone positive subset of patients with metastatic disease, and also the HER2 positive metastatic breast cancer subset. The outcomes for triple negative breast cancers is not that great, but still for a subset of patients, we have option of immunotherapy, targeted therapy. So definitely, as such, uh, metastatic breast cancer per se is a separate disease in 3 4 subsets, and the prognosis is definitely much better what is used to be.
So I think again you made certain very relevant points, like value of genetic testing is not for early breast cancers or locally advanced breast cancer, not only in the curative settings, even in the patients who present with an advanced disease in metastatic stages, that also that proportion of patients also probably we need to do the genetic testing, not only for the rest of the family but also for them also. So there is a big chunk of patients where identifying the right patient is something that is the need of the hour. Which are the patients which should be asked for genetic testing? And we all seem to agree in a way that the earlier we are able to discuss this, do genetic counseling with our patient and discuss this genetic testing, it is rather more meaningful, because there can be certain changes in the way we approach
Mm.
these cases. And understanding that gynecologists have a big role to play, both before the patients turn up to you and after the patients have come to you. So Dr. Asta, I would really want that, what role do you feel that gynecologists can actually play in spreading the awareness about, one is, first I will want you to address the awareness about genetic testing. Do you think any role of the gynecologist in that? And then I'll come to something else which is much more important.
So actually, I think we are the ones who will be seeing women in even when they don't have any health issues. Like people come for preconceptional visits, they come during pregnancy, they come for routine health checks. This is the time that we need to elicit a proper history and find out whether or not they are at high risk for breast cancer or any other cancer, and if they should be advised genetic testing. And we need to counsel them accordingly for that. Also, sometimes even if I send a patient for genetic counseling, the timing for that testing is important because it has a lot of emotional and psychological impact also on the patient. So we need to provide that support and guidance along with the oncologist and the geneticist to help them make that decision. And also, like you mentioned about age of marriage, age of childbearing, whether to give them contraceptive pills, HRT. So all those decisions are also around that. So we need to triage those patients. We need to find out those particular patients who will be suitable for genetic testing. And nowadays it is affordable, and people are aware about it. I think mainly because of social media and because of celebrities coming out with it. So it is now, awareness is not an issue, and people are open to testing also. So that's a good way that we can start a conversation, and people are accepting it also. But I think we need to give that time, and we need to invest that. That history taking and eliciting history is important for us.
Yeah, yeah. Thank you so much for the very relevant point. And something which I always felt was, apart from the genetic testing, another very big thing which is important in our scenario, what is the role that gynecologists can play in picking up breast cancer early, or early detection of breast cancers? That is something which I feel because they have lot of chances for opportunistic screening. So what are your comments on this?
So ideally, although we say that mammography is a good screening method, and we do advise mammography after the age of 40, but in India we see breast cancer at a younger age group. And that is not the time that we do mammography. And in our society, I think awareness before screening. So we need to make our patients breast aware. We need to guide them about the breast self-examination, which they should be doing on their own. And whenever they come to us as a routine check, we should be checking on their breasts. We should be palpating to, and also making them breast aware. And if a patient actually is coming with a breast symptom, like with any breast, when they've come for that, that is also a point for opportunistic screening, where I would, even in a young patient, I would like to advise an ultrasound or do an examination. But even if they're not coming with breast symptoms, I think it is our duty to spread awareness about the screening. And because early detection is going to be, it almost has a 90% cure rate. So that is the message that we should be giving them in a routine conversation in all our consults as well.
Yeah, I guess that is where there is a huge opportunity, and gynecologists, our colleagues, can actually make a lot of difference. And the way things have changed in the Western world, and with your support, things can actually change in our country also, where we will be picking up more and more of early stages breast cancer. And while we all seem to be in the panel today agreeing on certain basic things like, yes, there is a need of genetic testing in a subset of breast cancer patients, and the earlier we do, and there has to be a proper counseling for the patient, the genetic counseling, the implications need to be made, should be made understood to them, and the earlier we do, the better it is, not only for the rest of the family members, but it has got implications regarding the treatment of the patient themselves. And but on the other hand, we all also understand that in our country, in our resource constricted uh, country, there is a big gap between the demand and the supply. There will be a lot of problems regarding the costing of these tests, and then the different labs, the dependability of the labs, and plus apart from that, the genetic counseling, I mean the logistics, as Dr. Asta very candidly she pointed out, that it requires more time, it requires much more time from the busy routines, proper counseling, and there are so many aspects to the counseling that the patient needs to understand. So I would rather want a comment from each one of us, uh, I mean, what do they think while they understand? What do you think is the solution? How we can address the gap in our country? What are the barriers and how we can address that in our country? So, beginning with Dr. Kaushal, please. Dr. Kaushal, are you there?
Ma'am, please repeat your question. Your voice is interrupting.
So, the barriers to genetic testing in our country and the various gaps which are there, what can be done to increase awareness and probably close these gaps? Just 2 points from you.
Yeah, ma'am. Increased awareness should be there. Actually, we are sitting in the metro city, so we are treating the cancer patient. But if we'll go to the district hospital, they are not aware. Even physician, clinician, they are not aware about this thing. So this should be reached to each and every physician, doctor, surgeon, because breast surgery is doing, I think, in every district. They are sensitized first, so that they will sensitize the patient. Second thing, this genetic testing, this test should be provided at minimum cost. Cost is the most important barrier, because I'm sitting in the government setup. I can't ask every patient to go for the testing, because of the financial constraint, because it cost more than 5,000, 6,000 after giving coupon. So these are the most important gap, I think.
So very valid point. And again, I will want rather a comment from each of the panelists. This will rather be the closing comments on the importance of genetic testing and how we can, going further, how we can just close this gap. Dr. Prashant, if your views, please.
Uh, so thank you. So I feel that we need to make people aware, as Kaushal said, and I think this information has to percolate into the primary healthcare system, and as at the ground level, as the Anganwadi workers, and because they have actually made a change for cervical cancer and many other problems, health problems in India. Vaccination has percolated down. So I think, and awareness about vaccination also. So I think making a ground, the grassroots workers aware of the situation, and educating them about genetic counseling, and risk of hereditary risks as associated with breast cancer. So that I think could change the situation in India a lot. So that's what I feel. That is one important thing which we can do. Yeah.
So,
Anything more? So apart from that, insurance companies need to be educated. They also sometimes create
yeah.
hurdles in treatment of patients with genetic risks, but that's not fair, and that's not correct. That needs to go.
Yeah, I think you made a very relevant point. The insurance companies needs to be educated, and there seems to there. This I think is another chapter in itself, and another fight in itself. How to make them
Yeah,
aware and how to see that these cancers are then included in the insurance coverage or covers also. So,
absolutely.
Dr. Deepak, will you want to add on to what has already been said?
So, sir, so ma'am, the biggest barrier I feel is psychosocial stigma. Means Even after repeated counseling, possibly patients are worried, possibly if the test comes out to be positive. So how their families will take, how the society will think, that is the biggest hurdle I see for patients who are not doing the test. Because as such, for cost wise, we have now companies offering this test free of cost. So anyhow, we may not offer the treatment based on it, but still the main reason for not going for this test in my practice is because of the stigma.
Yeah, I think this is also another very relevant point. And as Dr. Prashant also said, one is the stigma. That is the most important thing. Yes, many families don't want to be labeled as carrying the genetic mutations for cancer. So that is a very relevant point. And other is also the insurance sector, which is another big gap when it comes to genetic all these diseases related to genetic mutations. These are, I mean, something very interesting and important points that have come up in this discussion. Dr. Pradeep, do you want to add on further?
So, madam, I think that has been extensively discussed that where is the basically we are lagging behind in the genetic testing. So probably that our physicians should be also be well aware of when to do that genetic counseling or genetic testing for our patients, and of course that patients should be sensitized. So we the physicians only can do that. That we can encourage our patients to do that whenever required this genetic testing to be done. And probably that availability of the test and the cost is probably now is affordable, but still a segment of population is not affordable for this type of. Even when I prescribe for my patients triple negative breast cancer patient, or even in ovarian cancer, when we in high grade serous carcinoma in stage 3 stage 4, when I give them that you should do this BRCA testing, germline BRCA testing to be done, but still they were not willing. Some of the time I am seeing that they are not coming. So is probably that is more sensitization required, and we the physicians only can do this, and of course that there are different social and that social stigma and all these things is contributing to this gap in the genetic testing.
So, Dr. Astha, your closing remarks, please.
So, very truly, as all of you mentioned, I think the main hurdle here is the awareness. So, I think even the primary health workers should be given, for PAPS, like for cervical screening, there is Viability, which is available at grassroots levels. So, similarly for breast cancer, explaining breast self-examination, so the Anganwadi workers and the primary health workers should be taught about that, which is a free of cost test, and it is very easy to do for detection. Also, they could be given questionnaires for that, which makes them easy for them to understand which family falls at a high risk, and they can be referred to genetic testing. So all this in the places where we are working are already having patients who are aware and can afford these tests, but the larger part of India is facing this problem. So if at the grassroots level we can do that sorting out of patients who will be needing this testing and can be referred through proper channels, would be more beneficial, I feel.
Yeah, thank you, Dr. Asta. I think all our panelists have brought up very, very important points that has come up today. And apart from, we all do understand that yes, genetic mutations are important. Testing for these genetic tests are important. They make a difference in the treatment as early in the treatment course. If they are tested, that does make a difference. But this information, this everything, this perception has also to pass on right from the oncologist or a gynecologist sitting in a tier 3 in a metro in a multi-speciality hospital. From a tertiary hospital, it has actually, the information has to percolate to the real ground level, to a physician sitting in a primary health care center, and even our Anganwadi workers. Even if apart from that, yes, we do understand there will be still be a lot of gaps, there will be logistics, there will be cost issues, but the everything that has to begin first has to begin with awareness. And equally, and rather I think another equally tougher war is going to be fighting the social stigma. The social stigma, the perception in our country about these inherited cancers, about these inherited genetic mutations. And there will be another big chapter that will open up when we talk to the insurance companies about the insurance coverage of these diseases. But nevertheless, everything begins with a step, and I do feel that Voice of Healthcare is doing a wonderful job. At least there is a start where people like you and me have started talking about it, and there are general public who are listening to us, and maybe it will make a difference in somebody's life. And last but not the least, when we all talk about precision medicine, precision cancer care, the latest advances in cancer management and giving the targeted therapies and everything, what we never need to forget is that prevention is always the best cure. And breast cancer happens to be one of those cancers where you can actually prevent it by modifying the risk factors. And if not, if you cannot prevent it, you can at least, it is one of those cancers which can be detected early with screening. So prevention at the end of the day is always better than cure. Screening tests are available, and it is required for each one of us, we oncologists, gynecologists, every one of us, physicians and the primary healthcare workers, to make our people aware more and more about screening, and more cancers to be picked up, and more of these cases to be actually be treatable and curable also. And with that, I thank all my wonderful and my eminent panelists for a wonderful discussion today, and hope the audience would have learned and would, I mean, somebody somewhere will be benefited with this discussion. And with that, I say thank you to all of you. Thank you for your time.
Thank you, and thank you.
Thank you so much, ma'am. Thank you.